Good morning. My name is Lynda Zeller. Thank you for joining this webinar today. On behalf of the Michigan Health Endowment Fund Chief Executive Officer Neil Haja and the entire squad at the Michigan Health Endowment Fund, we welcome you to today's webinar entitled From Crisis to Care, Michigan's Evolving Behavioral Health Ecosystem. Because today's webinar is only 60 minutes, and because we have more than 500 participants, we will not be able to dig deeply into any one aspect of a full crisis continuum. Even so, I'm confident you'll leave this webinar with useful reference materials and resources and new people to know, and that you will be energized to continue to do the hard work you all are doing in your communities. We're grateful for partners such as the Governor's Diversion Council, MDHHS leadership, including Director Hertel and key leaders such as Krista Hausermann, Dean Kubiak, and Stephen Mays, and many other fellow foundations who are all leaning in to help promote progress in this important area. Before I turn this over to our first speaker, I have some housekeeping items to cover. First, you may have already noticed that audio and video capabilities have been turned off for attendees. With the 500 plus people registered for this webinar, live question and answers is simply not feasible. However, we encourage you to enter all your questions into the QA box at any time. Our capable team at Wayne State University's Center for Behavioral Health and Justice will be compiling the questions, which we will address at the end of the webinar. We will ask our experts to address as many as they can during the webinar, and we will follow up with responses to questions during the event follow-up by the center, at which time you will also receive the slide deck, which will be presented today. Our first speaker is Stephen Mays, the Governor's Diversion, or MDHHS's Diversion Administrator, which also includes the liaison role with the Governor's Mental Health Diversion Council. Much of the seeding of this important system-changing work we are highlighting today was accomplished through the leadership, support, and hard work of the Diversion Council. Stephen's stellar leadership is key to the incredible boundary-spanning work happening in communities. Immediately following Stephen, Dean Cheryl Kubiak will provide an overview of the foundational work of this relatively new yet powerful center at Wayne State University. Immediately following Dean Kubiak, we will hear from Krista Hausermann, the section manager for crisis and stabilization services at MDHHS. Krista is leading some of the biggest crisis system developments in Michigan, including MyCal call lines and 988, and considering updates needed in policy and structures in order to maximize the full continuum of crisis care. Finally, Leonard Swanson, Crisis Response and Stabilization Manager at CBHJ, will provide a rich review of where we were, where we are now, and where we hope to go in Michigan in terms of crisis response and continuum. Leonard has been and continues to be an absolutely tireless, impressive leader with a gift for working with communities to maximize progress and working with local and state agencies to help us bust barriers to create smoother paths forward. Finally, in order to get the most out of the time today, I will not jump back in on video to introduce each of the speakers, but I'm entrusting each of them to do a smooth handoff one to the next. Now, as I said, and to kick off our morning, I am pleased, honored, and proud to hand off the conversation to my friend, Stephen Mays. Stephen?
Thank you so much for that kind introduction, Lynda. I really appreciate that. I'm really excited to be with you all today to help share with you some of Michigan's initiatives in the crisis response space, and especially how it intercepts with the work being done with the Governor's Mental Health Diversion Council. So I was asked to give a little context, sort of on a macro level, regarding the Mental Health Diversion Council. So I'll just start off with giving you just a little brief history. Back in 2013, then Governor Rick Snyder signed an executive order that formed the Mental Health Diversion Council. Initially, it had 14 members that represented state departments such as the Department of Health and Human Services, State Court Administrative Office, Department of Corrections, as well as leadership from the courts, law enforcement, both state and local, community mental health agencies, PIHPs, advocacy, the executive office, attorneys, and prison and jail reentry. What we found as we went on for about a year or so was that a big portion of what we could really help expand was that area of juvenile justice. So in 2014, another executive order was signed to expand the work of the Diversion Council to include juvenile justice and also expand its membership to include 4 additional seats at the table to help with those initiatives. So the Diversion Council acts as an advisory body to the executive office. And what we're looking to do is to seek out innovative initiatives to divert and deflect those with mental health issues, intellectual and developmental disabilities, and substance use disorders, divert and deflect them out of the criminal justice system and into treatment when it's appropriate. And with the goal of promoting data-driven best practices across the state to bring down recidivism, bring down the jail census, and to stop the revolving door in and out of the hospitals, which, as we all know, can become very costly for any community out dealing with these types of issues. Using the sequential intercept model, which you will be privy to here coming up in this presentation, the Diversion Council used the sequential intercept model as a roadmap and learned early on that early intervention would be the key to trying to divert and deflect folks. So what's the best way to really deal with those folks that are in the criminal justice system, in prisons and jails? The best course of action is to not have them go to jail or prison in the first place. So tying this all together with today's presentation and what the Diversion Council is really looking to do is to look at these early interventions, and which we've done early on with crisis response, mobile crisis or diversion centers. These are all key aspects of diversion and deflection, which the state has really looked intently on and continues to do so. And with the partnership with DHHS and what we're doing with the department and the partnership that we have with the Center for Behavioral Health and Justice, we just continue to dig into this issue and try to help the best way we can those that would benefit from it the most. So as my time winds down, I'm going to pass the baton off to my friend, my colleague, and fellow collaborator, Dr. Cheryl Kubiak, who is the Dean of Social Work at Wayne State University and is also the Director of the Behavioral Health and Justice for Behavioral Health and Justice. Dean Kubiak, the floor is yours.
Thank you, Stephen. It's a pleasure to be here with all of you this morning, and I look forward to the presentation. I want to start by saying, what is the Center for Behavioral Health and Justice? It is a center of excellence in the state where we try to bring research data to inform best practices through that data-driven decision-making model. Our goal is to divert and deflect as many individuals as possible with behavioral health disorders from the criminal legal system. Next slide. I'm very proud to show the reach that the center has had in its 5 years of existence. We are currently in 31 counties around the state with 5 different initiatives: diversion, treatment ecosystems, reentry, crisis response, and juvenile justice. How does this center, focused on diversion and deflection from criminal legal system, have anything to do with crisis response? And so the sequential intercept model, next slide, please, demonstrates what Stephen Mays was talking about. This is an organizing framework to say that intervention for those with behavioral health or mental health and substance use disorder issues can happen at any single link in the criminal legal system. And that includes what we call Intercept Zero, which is the community services. And much of the work that we've been involved in has been supported and informed by not only the Diversion Council, but some of the governor's task force on jail and pretrial incarceration, the Judicial Council, the Criminal Justice Policy Commission. And so our aim is to provide county-specific interventions based on data from that county at every single intercept to prevent people from penetrating further into the system, which makes it harder to get out. So thinking about this, one of the interventions that we had was funded by the Health Endowment Fund to look at the treatment ecosystem around the opioids. And specifically, we were looking at setting up the ecosystems in jails around the state, but part of it was how do people end up in jail and what's the mechanism that prevents them from going to jail or creates a continuum of care. So we looked at, specifically in Kent and Monroe counties, what was happening with crisis response. And this is where we learned a lot and where Leonard developed this model called PROACT. And basically what PROACT was proactive responses to overdose that linked individuals affected by overdose with systems of care in the community. And it was during this work that we learned a lot about the fragmentation of crisis response to the treatment ecosystems. So I want to say that there's a complete report. If you want to read any more about this, we'll link it into the chat. But just about the barriers between crisis response systems and treatment notification and entry. So that's what I'm hoping that you learn more of in the presentation that's upcoming. But first, I would like to introduce Krista Hausermann from MDHHS.
Thanks, Dean Kubiak. So, hi, I'm Krista Hausermann, and in March of 2020, through the internal reorganization, Michigan Department of Health and Human Services created the section of Crisis and Stabilization Services, demonstrating its commitment to developing crisis services for all Michiganders. We all know that feelings of isolation and loneliness are common in a crisis situation. These feelings are exacerbated by the complex and varied nature of Michigan's current behavioral health crisis services. For most Michiganders, access to crisis services is defined by their insurance status and the region where they live. However, this is changing. There's a lot of exciting work being done across the state. MDHHS is partnering with a wide array of stakeholders to develop a crisis system for all Michiganders based on the three primary components recommended by SAMHSA. Someone to call, which is 988, and that's now statewide in Michigan. Someone to respond, which is mobile crisis, and somewhere safe to go, which are crisis receiving and stabilization units. This system will be a safety net for individuals and families, offering hope and connection, maximizing the integration of people's support networks and local community resources. We're still in the process of tailoring this model to our state. 988 is the centralized, easy to remember statewide access point for people in crisis and distress. And as I said, that's statewide and active all across Michigan. For Michiganders who need more than phone, text, or chat support, 988 will link the person in need to a local 24/7 crisis service hub. The hub will help determine which local crisis service best meets that person's need and ensure that the person receives the service. The other two components of SAMHSA system, the someone to respond and somewhere to go, will be offered through the hubs. Now, at this point, I'll turn it over to Leonard Swanson from CBHJ, who will share information about all the exciting things that are happening at the local level, as well as areas for improvement.
Thanks, Krista. And hello, everyone. Well, welcome to our webinar. I'm excited to show all of the exciting things going on across the state, as well as some of the work we've done to figure out what's going on in the state and show some of these programs can be pretty promising. But I guess before I get into kind of the good news of crisis response, it's worth discussing what the problems are. So by the problems, I'm talking post deinstitutionalization. I know that's a long, expensive word, but by that, I mean, what happened after we closed the mental health facilities in the 60s and 70s that really housed people a lot of times against their will in facilities. And we opted for a more community-based mental health program. So how do we provide services to people in crisis in community without burdening other systems? And unfortunately, since then, we've run into time and again other problems of where do we serve folks with mental health crises. And unfortunately, some of our largest mental health facilities are our jails, not only in the country, but in the state of Michigan too. We have too many people with serious mental illness in our jails. So part of the work we've done as a center is actually doing screenings for everyone walking in jails in 19 different counties in the state. And we show prevalence of about 20-25% of people walking in the door showing signs of serious mental illness. And 25%, I mean, that's quite a lot, right? In the general population, just 5%. And so anyone who's been in a jail before can tell you it's not the best place for treatment. It's not ideal. So there's risk of decompensation. By that, I mean signs and symptoms of someone's serious mental illness can get worse. I mean, especially you can't get any medication you want in a jail, right? They have limited capacity and ability to give certain medications. And, if we're not able to continue treatment, things can get worse. We know people with serious mental illness are more likely to be victims of crimes rather than perpetrator. And that's especially true in criminal legal facilities as well. And so that just underlines the general point of inadequate mental health care in criminal legal systems. And that same study I talked about where we screened folks coming into jails, we also tracked and see how many actual people got into services, and really they're not enough was the main finding of that study. You can check out there. Not to mention Medicaid, not allowed to bill Medicaid for jail services, all hosts of problems and facilities that clearly weren't built or designed to serve people with mental illness. And yet that's where a lot of our folks are. Now, the kind of default place to bring someone these days is the emergency department for psychiatric reasons. And that can be an appropriate placement, especially if there's general physical problems as well. But we also run into problems at emergency departments. So we often struggle to connect people with ongoing mental health care. There's a number of studies suggesting that link between the emergency departments and the care afterwards, could be stronger. It's not a consistently effective place for law enforcement to bring someone. Sometimes the law enforcement can bring someone and it might take a few hours of that, not only that person's time to get the care they need, but for officers to make that link and want to help their other officers on the road, that can be, a system problem as well. Or officers can spend several hours trying to convince someone, to come to the ED for treatment, and they find out after dropping someone off, it's a quick turnaround and the person's out on the street again and without the care they need. So another problem. And on top of that, I mean, there's cost problems too. I mean, for the consumers, ED bills, aren't always cheap. And then a lot of folks with serious mental illness, there's a lot of link with unable to pay for insurance. Sometimes people don't have insurance or are on Medicaid. If you have serious mental illness, it's unlikely you have a high-paying job. It's more difficult to do that. And so that poses some other financial problems for our larger health systems and EMS and what have you. So in addition to the emergency departments, there's also struggles with finding hospital beds. So for those unfamiliar with the system, process if you drop in an ED and then they screen to see if you get into an inpatient hospitalization bed, which is a higher level of care, more intensive, and can be pretty traumatic. So a lot of times this is happening against someone's will. And it's, as you can imagine, it's difficult, and we try to avoid that as all possible, but it is necessary in certain circumstances. But one of the issues we run into is what we call ED boarding. So you can spend days or almost weeks at an emergency department waiting to get into a psychiatric hospital. And that problem in Michigan has been made even tougher since we've closed a number of different psychiatric hospital beds in the last year or so. Not because we don't have the physical space, but just the staffing to be able to support these beds. It's all the more difficult. So I say all this, it's not as if, these, we should avoid these at all possible. There are situations where public safety is at risk and jail is the appropriate solution, where ED and psychiatric hospitals are appropriate. I would say by and large, we're putting too much strain on these systems, and there are ways we can divert crises from EDs and jails before they rise to this level. And that's our ultimate question here. How do we divert crises from jails and hospitals upstream? How do we avoid using these intensive resources, which cause all sorts of problems? And the answer to that, which I hope to get to on these slides, is a comprehensive crisis continuum for all Michiganders. So as Krista said, SAMHSA, which is the Substance Use and Mental Health Service Administration, they laid out these national guidelines for what a crisis continuum care needs to look at. And it's got these three components that Krista mentioned earlier. Someone to talk to, as in over the phone, someone to respond, as in, teams of mental health professionals actually meeting you where you are physically, moving out in the community, and a place to go. So other than emergency departments, but crisis stabilization units and similar kind of units that I'll talk to. So I'll spend the rest of this time talking about kind of what's going on in these spaces, about someone to talk to, someone to respond, and a place to go, and where are some kind of promising aspects of these innovations that we're seeing across the state. So it's worth kind of seeing what our systems have been and what they look like now and traditionally. So we have, I like to draw a little physical maps about how people kind of flow through these systems. And right now, by and large, when there's someone to talk to, a lot of the default answer is 911, right? I wouldn't call that unreasonable too. You don't have too many numbers, and top of your head, 911 is easy to remember. And it's, if you see an emergency, that's what we've been trained to do, right? And so 911, a lot of their default responses is send law enforcement. So we don't quite have the systems in place where 911 are sending these kind of mobile teams or co-response teams, but I'm just saying the default response in probably most of the country and most of the state right now is sending 911 and law enforcement. And as you can imagine, I mean, we all read the news, these certain cases can go wrong in terms of fatal interactions or arrests or use of force that we try to avoid. And there's ways of, training law enforcement and trying to de-escalate as much as possible. But to their point, I mean, they have limited options about what they can do with these cases as well. So one common option is went through earlier is jail. We know that there's an overpopulation of people with serious mental illness in our jails, but it's not like we have a ton of other options either. Emergency departments are kind of the default place that law enforcement can bring people to, or they can try to de-escalate and resolve the situation at home, right? So this is kind of where our systems have been. So where do we see this crisis continuum? As Krista mentioned, 988 and local crisis lines are another option of increasing awareness of these resources to try to talk to someone if you have suicidal thoughts or if you know someone that's struggling. Getting that option out there is important. Some communities are able to have mobile crisis teams and co-response teams, which I'll talk about in a little bit, of actual mental health professionals going out on the scene and serving people in crisis. And they tend to know their local resources well, including places that we call crisis stabilization units or other similar kind of facilities that are really built for mental health crisis, behavioral health crises that tend to be lower cost for consumer, kind of run by the local mental health agencies, and they're sort of built to handle these kind of situations. And of course, when mobile teams go out, there will be situations where resolving at the home is the clearest solution, or transportation to an emergency department is clear and necessary in those kinds of situations too. It's not like we can de-escalate all of the calls. But the point I'm trying to drive home is, how do we establish these flows from our traditional system of 911 law enforcement to this crisis continuum that we're trying to build here in Michigan and across the state? How do we build these interdisciplinary connections for people to flow to these resources that we know can handle these behavioral health crises going on in the community? So for the next few slides, I'll talk about these three options: someone to talk to, someone to respond, and a place to go. So I'll probably spend the least amount of time talking about someone to talk to. I think Krista Hausermann, thankfully, my co-panelist, is our guru when it comes to 988. but I'll talk a little bit about the research we've done in this area, specifically with 911. So commonly referred to as dispatch, but their nomenclature, they like to use this term PSAP, or public safety answering points. And we did a survey a couple of years ago, just asking about how they handle behavioral health crisis calls. How do you even recognize what a crisis is? How do you route calls? How do you know about CIT programs or crisis intervention team, kind of officer training programs, and how those are operating? And what we found is, what we asked about this kind of routing thing. Do you actually get calls from crisis lines, or can you refer calls to crisis lines? And right now, the situation is crisis lines more often are referring to 911. So they operated by the CMH usually, and they take a call, they see the situation's a little more dire, and they send it to 911. But these PSAPs, 911, by and large, are not sending calls to crisis lines or 988 the other way. We have to develop these kind of interdisciplinary trust and some protocols that routing can be possible, that both institutions are comfortable with it and can route appropriate calls to the mental health system. But at this point, where we are right now, it's kind of not happening as much as we would like it to. So one of the exciting ideas we kind of hear about in the field is embedding clinicians in a 911 dispatch office. So this is kind of popping up in some of the innovative areas. So Houston, Texas, Broome County, and New York, and I know Arizona has a program like this where they actually bring a mental health professional from the mental health system and actually place them at a 911 kind of PSAP office. Some benefits here: you're able to build trust between the systems first and foremost, and then figure out how to route calls appropriately. There's been a little research that they're able to kind of route more calls to mobile crisis and co-response from 911 after that system building has been done. There's obviously pieces to figure out. I know Detroit, Michigan is piloting this program. Really excited to see any data coming out of that. Would be really promising. Would love to have some kind of evaluation on how that's working. But just an idea that we've heard about that we're excited about. So 988 is another option that Krista described earlier. So this went live back in 2022. And so this is national level legislation. This isn't just a Michigan thing, where it's the suicide crisis lifeline across the country. And so this is sort of split up against a number of different local crisis centers that handle these calls. And in Michigan, the predominant call receiving location is MyCal, Michigan Crisis and Access Line. So if you're in one of those light blue counties, if you have a phone with those area code, that'll be the service receiving those 988 calls. And depends a little bit on jurisdiction, but I won't go into too much detail there. So other lines that exist are called CMH crisis lines. By CMH, I mean community mental health. So each CMH kind of operates their own crisis line. If you drive around the city of Detroit, like on 94, 96, you'll see those billboards for those kind of crisis hotlines, right? And so that's sort of a number you call to get hooked up with local CMH services. And that's likely to get kind of a direct program with CMH. So this is different than 988. This is the mental health organizations kind of have their own number. And you can kind of see that some of the agencies serve a number of counties in there. But again, I won't go into too much detail here, but just giving you an overview of the different kind of call options. So 911 is probably the predominant one that we see most often that people call, but we have some system building and some system routing to do before we can kind of route these calls. There's a lot of kind of trust building and challenges to work through there. 988 MyCal is new for the country and new for the state. Went live recently, and they can handle those suicidal calls. Whereas the local CMH crisis line is something different, really direct connection to the CMH programs. But you got to kind of know what number you call, right? You got to know, at least look up the right number for your area. It's a little bit of a hurdle, but more direct connections to the CMH programs. So something I'm looking forward to talking about here is someone to respond. So there's been a lot of models popping up in the last few years of different ways of responding to mental health crises out in the community, right? So I'll talk about a little some of the different models that we see here in Michigan, and there's some popping up nationally that you might have heard of that really exciting, and we don't have much of a evidence research base behind them yet, just because they're so new and emerging. But this presentation, I'm excited to share with you some new data that we've been working on over the last year with some models in Michigan. And there's quite a lot of models out there. So I'll try to break down what we're seeing across the state of Michigan. And so I'd say the predominant model that we're seeing most of the state are these kind of on the far left, the office-based crisis response. So this is usually at a CMH office. So the CMH, the public mental health system, usually has some kind of office. They're not always built to receive crises walk-ins, but there are clinicians there, mental health professionals there, and they will see people that experience a crisis. So it's tough to get people to be out in the community. Whereas this second model, the mobile crisis response, meaning how do we get mental health professionals outside of a hospital or health care facility to serve people in crisis in homes or public places. So this is what we mean by mobile crisis. This is typically run by CMH or one of their contract providers of mental health professionals being out in the community outside of a hospital or healthcare facility. On the right, we have co-response models. So usually referring to mental health professionals teamed up with law enforcement. And by these models, these are clinicians sort of that show up to work at a law enforcement agency, responding to calls that come in through 911 or that police notice, as they're doing patrol. So the main difference I would say with co-response and these other models is where they're getting their calls from, right? So you usually get calls through 911 and they're responding live, or they do some kind of follow-ups, but the kind of route of those calls is kind of through these traditional 911 systems. And so we've spent the last year trying to dig into a few of these models that exist across the state. And I'm obviously not going to read all of the details on all these models. And these aren't the only models that exist, right? There's mobile crisis in other areas. There's new co-response models popping up. But these are just the 6 that we spent some time studying over the last year. And so you can kind of see by the little color shading and then the model, how we decided what model type to categorize them. And kind of what agencies were playing a part in serving folks and kind of where they are predominantly in the community homes and a lot of these facilities. But the one part I do want to highlight is how they are being paid for. So these models kind of closer to the right, I would call them more robust models, where they're actually going out in the community more. They're actually getting separate funding to do this. So Jackson County, Hillsdale County, Washtenaw County, they all passed millages on a county level that pulls tax dollars from property tax to actually support mental health clinicians doing these kind of services in the field, among other things that the counties are using the mental health millage for. But this gives them the flexibility to offer these services kind of beyond Medicaid and beyond general fund. And these co-response models have a similar kind of structure, right? These, I have Oakland County and Wayne County there, but specifically, it's those cities that I got in the parentheses there. So Auburn Hills, Birmingham, Bloomfield Township, Livonia. All of these cities have supported these models through municipal dollars to the law enforcement, who then contract with the mental health provider for a clinician that actually goes out in the community, sometimes with law enforcement or sometimes following up after cases to de-escalate and serve people with mental health crises, diverting them from emergency departments and jail when possible, right? So it's difficult, and I'll come back to this point. It's difficult to get these models going right now under our current funding structures. These millage and local municipal funding has really been the catalyst to get these advanced models going. And so why are we so excited about these models? Where we've got some data suggesting that there's pretty promising things going on. So there's a lot of data going on the slide, and I'll try to kind of break it down as much as I can. So on the right, you'll see some data on law enforcement responses to mental health crises. So these are all mental health calls and suicide calls and police reports that we actually read through and had to pick out, where did the person end up and how did you sort of notify the next link in the system. And predominant law enforcement is to take someone to the ED, right? The chart I showed earlier, right? 62% of the time, their method of contacting a future mental health intervention is through the ED, right? And so, there are issues with, picking up the ball after that. About 10% of the time, they actually directly notify the CMH, which we like to see, either at a live call out or referral to CMH afterwards. But again, 28% of the time, law enforcement shows up, and that's That's kind of all that happens, and we don't have a link there. Whereas if you look on the kind of left side of this chart, you have the different CMH models. We have the office-based on the far left. In the middle, we have the mobile crisis and co-response on the right. And in all of the models, at least half the time, there's a follow-up appointment set up. And so that's really key, especially for this kind of population. I mean, it can be tough to sort of keep track of things, or what's the next step, and crises don't always last one day, right? I mean, if you're experiencing a crisis, it's often a recurring problem. So these kind of follow-up appointments and continued linkage with ongoing service is really, really important. And then we are seeing some positive things in these CMH models, whether that's office-based, mobile crisis, or co-response, to see that follow-up appointment at least being set. And the models often give resources as well. And then co-response, there's sometimes where linkage was not possible. So encouraging things of connecting people to the next service after that initial crisis. We also saw some interesting pieces on transportation. So kind of before I get into the thick of the data here, I'll first note that these weren't apples to apples comparisons, right? So it wasn't as if we were able to randomize the service response in a case. We didn't have that much, evaluation control. We were just looking at these kind of different models in 6 different places and try to see what happens. So it's possible that the law enforcement and co-response cases, since they came through kind of 911 calls, those could have been inherently more dangerous. Those could have required more ED transport. So with that caveat in mind, what we did notice when looking at all the disposition outcomes of these models is that still law enforcement are predominantly taking people to emergency departments as sort of way to resolve the situation, right? See 70% up in that top left of all law enforcement dispositions and transportation were to an emergency department. And that co-response category, they also get their calls from 911, 43% of the time taking emergency departments. Whereas the office-based and mobile crisis, a lot of the time they're able to resolve informally, which we like to see. Could be different kinds of crisis, but I think there's also something to be said about having a mental health professional there, being able to de-escalate and being able to kind of relate to the person professionally to avoid things escalating to a level of care that may not be necessary. So these kind of co-response models, at least the sites that we studied, had this option of drop-off centers, which I'll get to in a few sites. And so we saw, 11% of those were able to go to those kind of mental health treatment facilities, and a few of the co-response and law enforcement did result in the rest. But I do want to drive home that this ability to resolve cases informally, right? It comes back to our central question: how do we divert crises from jails and hospitals and the 8 emergency departments upstream as much as we can? And so these models are promising, at least to me, in their ability to resolve cases, so we avoid some of the downstream problems we know that exist with emergency departments and psychiatric facilities, right? Whereas, we know that the predominant transportation that law enforcement have are emergency departments, and unfortunately, a lot of those cases, it wasn't always a great time, right? So 70% of that 70% were involuntary transports, and so we looked for particular language in the law enforcement report narratives, and was it voluntary, involuntary? We looked for kind of language, and wasn't always a pleasant experience. And a lot of that had to do with kind of protocols of, if police have to transport, sometimes handcuffs are, it's policy to do that. But it's worth at least looking at some of these pieces that can be potentially avoided if we're able to introduce mental health professionals earlier on. So some promising pieces as part of the some of the response. All this, and I haven't even talked about the overdose epidemic, right? Newsflash, it's still happening, and there's dire outcomes. So I won't go into kind of all the evidence behind it, but generally we know if someone overdoses once, they're at much higher risk of a subsequent overdose, right? Very, very high risk of death in the following year, not only of overdose, but a number of other health-related diseases, suicide, respiratory diseases, et cetera. But we kind of face the same system problem of a struggle with linkage from emergency departments to that care afterwards. And it's even harder with people with substance use disorder who may be resistant to seeking treatment, right? It's some people want to continue to use, and there's ways to do that safely, but kind of seeing this whole treatment system as a large step can be pretty intimidating for someone, especially if they just experience an overdose. So one program that Dean Kubiak alluded to earlier is this model we developed in a few communities, what we call PROACT. So proactive response to overdose and appropriate connection to treatment. And this is something where we facilitated connections between first responders and our mental health system. And in this case, actually recovery coaches who sometimes work for community mental health agencies, sometimes work for harm reduction agencies who can meet with people who experience that overdose. And so recovery coaches are people who have been through substance use disorder or substance use issues that have walked the walk and are skilled at relating to people who've gone through this really difficult situation of overdose, right? And so we enabled a way for EMS organizations, so emergency medical service ambulances, to share data with these follow-up agencies, whether that's a harm reduction agency or community mental health, to actually know who the patients are to perform those follow-up services at their home. So sometimes at the incident location, but most often at their residence address, in the following day. How do we get those follow-ups happening to offer naloxone kits, sometimes syringe exchange programs for people to use more safely? And there's a whole host of evidence on harm reduction strategies, improving health outcomes. And if someone's ready for treatment, they're able to introduce that option as well. And so we found is, it was sometimes difficult to track the folks down or know where they are. Sometimes the overdose happened at a parking lot or a public place, and it's difficult to get in touch with the person. But when they're actually able to make contact, we found some really encouraging outcomes. So we did it in 3 different counties, and over 200 people we were able to make direct contacts, and a majority, almost 3/4 of folks, were interested in that resource information, receiving the naloxone kit, and fentanyl test strips. And testing a substance to see if it has fentanyl in it, so to promote safer use. So majority of folks, 74%, interested in that level of resources. And almost half of the people the recovery coaches talked to were also interested in some kind of treatment. So that being meeting with a recovery coach, outpatient treatment, inpatient treatment. And for this population, it's really encouraging. I mean, there's a lot of reluctance to seek treatment for folks in sort of the active throes of substance use. So seeing this kind of engagement was something we were really excited about. Understanding, about a quarter of people refuse, and you'll have that. But noting how can we get these right mental health professionals and recovery coach professionals on the scene as part of these criteria. So takeaways. So compared to our kind of traditional law enforcement response, the CMH responses, by that meaning mobile crisis and co-response, were able to connect people to ongoing care outside of emergency departments, right? Deflecting people upstream from EDs and jails. Unfortunately, the way our funding is set up right now, it's very service-based. Medicaid billing, doesn't allow for people to be standing around waiting for a crisis, right? They only fund you if you do the service, and you don't always know what their insurance is. And then hopefully that's not the first question you're asking when you're out in a crisis, right? Are you able to pay for me to get out there? Right now our funding structure is a little cumbersome. So the most advanced models that we see have this extra bit of funding through millage dollars and local municipal fundings to offer these kind of mobile crisis co-response. I would not say it's the norm in Michigan, but there are exciting things happening when we see these units exist. So our comparison groups, it wasn't a gold standard of research here. We were just looking at different samples, but we did in the law enforcement samples see more arrests and more use of control enforced in those samples. And if we're able to find recovery coaches and introduce them to overdose incidents, that's one way of looking at the overdose epidemic and really establishing connections that weren't there before. So someone to respond, some exciting models out there and ways to divert people upstream. Last section I'll get to is places to go. So there is right now the predominant model is emergency departments, but there are also these some of them new units, crisis stabilization and psychiatric urgent care units. So different places to go if you're in a mental health crisis. And I'll talk about the kind of gold standard that we see in Michigan, and it sounds like there's more of these units that are coming down the pike, which is really exciting. But by this, I mean crisis stabilization units. So this is a brick and mortar facility outside of emergency department, and by that I mean a separate door where it's typically operated by the community mental health agency or a provider that is closer tied to the mental health system. It's usually a lower cost for the consumers as opposed to ED bill, and it provides another option for not only law enforcement but just people in crisis. If we work with law enforcement is often operate out of practicality, right? I mean, this option, this option, this option. This is another one of those options of a place to bring someone in certain crises. But one thing to consider: it's always expensive to build a new facility, not only in terms of the brick and mortar, but also staffing it, right? If we want to build out a crisis system for anyone, anywhere, anytime means 24/7, right? And that means having the people there at the ready. So there's some examples of this in Oakland County, Wayne County, and then Calhoun County has one called a psychiatric urgent care. So it's not quite at the level of crisis stabilization units, but it's still a model that we're excited about. So they established what's called first steps. So this is a psychiatric urgent care that opened in March of 2021. So they do the walk-ins and voluntary crises, open 24/7, and they have different entrances for law enforcement. And what we were excited about is we have some kind of state level data of all ED visits and how many of those were psychiatric related, right? And so on this kind of chart on the right, you can kind of see that on the green is that kind of state average, what the rest of the state was doing. And thankfully, we're kind of seeing a gradual decline. In Calhoun County, that purple, we saw kind of a gradual incline, not the direction we want to see. And that percentages of all the ED visits, how many were psychiatric related? It was really encouraging as we see that drop right after the psychiatric urgent care center opens, right? Implying that some of these cases may be diverting to this urgent care away from emergency departments, which is pretty encouraging. This isn't the most kind of robust data. We weren't able to do a lot of advanced statistics of it, but at least it's a good sign that we're seeing that drop in psychiatric related ED visits in Calhoun County after they opened this psychiatric urgent care center. And there's always more work to do too. So this is another site we studied a little more in depth in another county that actually had this crisis stabilization unit. And what they did, they not only had the unit, but they trained officers that it exists as a resource. And so this training of officers in this county was known as CIT, or Crisis Intervention Team Training, where it's 40 hours of training. They let law enforcement know about mental health conditions, some different de-escalation skills that work for this population, but also they let them know about local resources that can be helpful. And so this kind of chart for those other nerds in the audience is the interrupted time series, where we see the trajectory of drop-offs to the stabilization unit. And here's that police training, and 38% times more transports to this crisis stabilization unit after you actually tell someone about it. So it's not enough to just build it and they will come. There's actually these interdisciplinary work that needs to happen of all of your whole crisis system getting on the same page about what your resources are and then how do we actually make the best use of it. So it was also encouraging as we saw fewer transports to the ED, the local ED, after that training took place too. So more transports to the crisis stabilization units and fewer to these EDs. So location matters as well. So we actually did this study where we looked at the location of the crisis incident and where this stabilization unit was in this particular place. And distance matters. So for every mile away from the center, officers had a 1% less likely to use it. So further away the center, less likely to use it. So it's great that certain counties have these stabilization units, but it's not like we can expect our first responders to drive 3 counties over to this facility, right? So that actually calls for a need for more of these units in more convenient locations so that they're a real feasible option for people in crisis. And so I'll wrap up with our place to go, right? These units are promising. There's a little bit of research showing and a little bit of data suggesting there can be ways to divert people upstream from emergency departments and jails, right? It'll be costly to implement a new facility and to staff it. But if we're able to get that interdisciplinary coordination, we can really maximize the use of these new innovative programs. And by that, we mean coordinating 911, law enforcement, mobile crisis, really the whole crisis system, a comprehensive crisis continuum for anyone, anywhere, anytime, right? So that includes someone to talk to, working with the system bridging with 911 and 988 and these other lines. How do we get our mobile teams to be able to get to respond to calls through 911 and 988. That's another question we're going to have to work through to route calls to our crisis systems. Someone to respond. How do we get more of these mobile crisis and co-response teams out in the rest of the state, other than these places that have this extra funding to pay for it? You know, right now, it's difficult to get those models off the ground. I know Blue Cross Blue Shield has offered a way to privately or to reimburse private insurance, but it's not the case for all private insurance. And so until we have the ability to bill any insurance, I think we're going to struggle to get these exciting models off the ground the way I think we need to. And then crisis stabilization units, a fantastic option as another place to go. Can be expensive to implement, but it gives a concrete way to divert people upstream from emergency departments and jails. So that was quite a lot of options, and I hope I gave you all some innovative ideas of ways to divert folks who are in crisis away from our kind of traditional ways and to divert more people to care when needed. And with that, I'll turn back to Lynda Zeller, who hopefully will do some closing remarks and ask us some questions.
Great. And can you skip to the next slide so we can see the other panelists' names too as well, Leonard? Thank you. The first question, we're only going to have a chance for a couple. So first, I want to say this is obviously a very well-informed audience who has asked some amazing questions, all the way from AOT to existing crisis residential services to how our lines not confused with all these lines we have for crisis calls, all kinds of things that are super important for us to answer. We will, with the help of the stellar leadership from the center, we will provide answers to as many questions as we can in the feedback that comes back to you, including these slides. So I'm going to ask just a couple quick questions. First of probably Krista or maybe Stephen too, probably Krista. Michigan has been a leader for a long time through its specialty managed care system in things like crisis residential, and that's been a benefit for a long time. Is crisis residential still a key and promoted part of the continuum?
Yes, it is. There is so much happening in the crisis field right now that it's hard to balance it all. And crisis residentials are very important. They are going to be included in our psychiatric bed registry as an option for a crisis placement. Crisis stabilization units as well will be required to coordinate with them because they are a placement where somebody can go when they need a more intense level of care than a CSU, but less than a psychiatric hospital. So yeah, they still remain a very important part of the continuum. And I am well aware that there are some ways that in Michigan we could work together to improve those services. And so we will get there.
Thank you. This next question, Stephen, you may want to come back on video. Hopefully you're still there. This could be for Stephen or Leonard or Dean Kubiak. Can you talk to us about AOT? It seems like it's underutilized and there's barriers to who can order it. What's happening with AOT, assisted outpatient treatment?
Well, I can say from the state level that this is an issue that is being taken very seriously by the Diversion Council. In fact, so much so that we've put together a subcommittee to deal specifically with AOT. With that in mind, there's still some confusion across the state as to how it's utilized and how it can be administered. And so as a result of that, we've partnered with the Center for Behavioral Health and Justice to put together an AOT toolkit that deals specifically with all of the issues and all of the partners that could possibly come in contact with a person in need of an AOT. They've outlined several different aspects, including the CMHs, law enforcement, the hospitals, advocates, families, so the list goes on and on. So the toolkit will address in general how AOT should be looked at, and then also individually for each one of those sections. So from the state's perspective, the Diversion Council has been actively involved in the language revamp of the law, the current law. They did it back in 2017 when Kevin's law was revamped. And so now, even in 2023, there's still some communities that are challenged by some what they view as confusing language. And so we're looking at trying to address that on a legislative basis as well.
Thank you. Cheryl, did you want to add, or are you good?
I just want to say that the center is doing a great job of working with the Diversion Council on creating this web-based tool that will allow a lot of standardized information to communities to set up AOT and to work across multiple sectors in their community to roll it out.
And I understand that there's going to be an AOT webinar coming up soon. So to address some of that, so I would suggest that you reach out to the Center for Behavioral Health and Justice for information in regards to that as well.
Thank you very much. I'm going to pitch, we have time for like 2 more questions, I think. I'm going to pitch the next one to myself. And it's a great question. The different responses for them to be effective to the communities they're going to serve need to involve engagement of the communities. Very specifically, how are we involving Black thought leadership in this response? So I can't speak on behalf of the Diversion Council of the state, but I can tell you that philanthropy is engaging with the state, with locals, with PHPs, with Medicaid health plans. We personally at the Health Endowment Fund have worked with the state to disaggregate some data about Medicaid that has showed there's a 3 times worse timely access to treatment for the Black population as compared to white, and also a similar challenge, not quite as broad-based in scope with tribal populations. So there is not enough work going on in this space, I can tell you that. And however, foundations, the state entities and local entities are trying to be better about engaging in this particular effort, community-based organizations who can inform us. We're doing work in 4 counties that's pretty deep right now. So I'd love to know who answered this question, because I'd love to give you the names of some of the community-based Black thought leaders who are doing the effort in this space. Also, a collaboration of funders led by Blue Cross Foundation are also doing some Black-led work in the Detroit area. So great question. Thanks for the reminder, and we need to do more, and we look forward to hearing your ideas in this space. One final question. I think this one's probably for Krista. How are we dealing with the confusion around 988 and MyCal and the CMH lines? And can you call any of those and end up in the right place? And how does 211 and the wealth of referral sources factor into what happens with a person when they call? So this will have to be the final answer.
So first off, MyCal was legislated by the state of Michigan prior to 988. So we have made a decision that with the institution of 988, we are not publishing the MyCal number anymore. MyCal staff answer the 988 crisis line in Michigan for either as primary or secondary. They answer about 85% of the calls right now. And they also answer other crisis lines. In terms of the CMHSP crisis lines and 988 crisis lines, there's a difference. 988 crisis line, that's for all Michiganders. It's a nationwide line. And there are so many people that don't see themselves as being eligible for CMH services, and they don't know to call that line. Like maybe they're new to the area, or they don't know what number to call. The other thing is that CMH crisis line those lines are very important and need to remain in existence, because they are an integral part of a coordinated system for some of our most vulnerable Michiganders. And they really integrate that crisis care into the treatment people are seeing. In Michigan, the purpose of the CMH crisis lines, it varies. A number of the CMH lines, they're during their day, they're access lines. So they don't have that same ability, all of them, to provide 24/7 support for people in distress, which is a key part of 988. And so there really is a difference. We're working hard as we roll out presentations and talking with people to explain this difference. What it comes down to, though, is if somebody calls either line, we'll get them the help they need. And so I think that's what's most important.
Thank you, Krista. And thank you to the whole team who put this together. And more importantly, for the 550 odd folks who joined us, who are really, I know a lot of you are doing this heavy work in your community. And it really is system changing work, and it's hard and it's complicated. And we just have to be brave and soldier on and keep sharing learning like this. So we thank you for your participation. We thank you for your hard questions. We will do our best to get you what we know. And if you have resources you want to share, please forward those to us as well. Again, thank you to the whole team, and especially to the center for doing all the heavy lifting on this webinar. Thank you and have a great day, everyone.